Assalamu alaikum. The short clinical station day. First scenario, Miss Carla, 43 years old, female with complaint of weakness. Please examine the upper limbs of the patient. Yes, you can start.
Il n'a pas su défendre. Ensuite, axe.
Hello,
I
doctor.
will.
Yes, start.
Yes.
You can start.
Okay. I will welcome the examiner, then go to the wall, see the instruction, and wash my hand and go to the patient. I will take permission. Hello, I am Dr. Muhammad. I am one of the candidates today. I will examine you. Any pain, tell me. I will stop on time. Any pain now? Any pain now?
No, there is no pain.
Okay, I will start by surrounding any walk aid. I see
No.
some collar, cervical collar, soft collar.
Okay.
Any other surroundings?
No.
I will start by general inspection for the hand, any wasting, or I will touch the muscle, any fasciculation, any atrophy.
No, there is no muscle wasting.
Okay, any special positioning for the arms?
No.
Flexion or extension? Okay. Any scars?
No.
Okay. I will look at the back of the neck, any scars?
No.
Okay. ماشي.
No. sir.
Okay, I will check the back of the neck, any scar?
No.
I start by tone from the wrist and forearm, flexion, extension, and rolling for the arm, both sides. Any
There is
hypertonia?
hypertonia. Yes, there is hypertonia.
Any differential between both sides?
No.
Okay, I will start by power. I will tell him to put his arm upside and flex the flexion of the elbow, and I will start to check for abduction and abduction. Any weakness?
Yes, there is weakness.
Abductor or abductor?
There is pyramidal shape of weakness.
Okay, the same. I will test the power on the elbow. Same pyramidal.
Yes, pyramidal shape of weakness.
So abductor more weak and flexor more weak, right?
Yes.
Okay, distal or proximal, I will take him first my hand, distally or proximally more.
Distal is weaker than proximally.
Okay, I will test the reflexes from the triceps and biceps, then triceps, then the brachioradialis.
Biceps reflex is absent. Triceps reflex is hyperreflexia, and in the supinator there is flexion of the thumb and index fingers when you do the reflex.
I will do Hoffman sign. It's positive also.
Positive, yes.
Okay. What about I will test for coordination, finger nose test, both sides. It's okay.
Intact.
Okay. I will test for sensation. I'll start by anterior column. One, I will check in his face or his arm, on his chest to compare from different dermatome. It is okay.
Yeah.
Pin touch.
Yes, slight touch and pinprick sensation are intact.
Slight affected variable between both.
Intact.
Intact.
Yes.
Okay. What about the deep sensation? I will test by position from the distal two. I will ask the patient to show him first, up down, close his eye, and tell me it is intact.
No, it's not intact.
So
It's impaired.
deep column sensation impaired, right?
What?
Deep column impaired position.
The position is impaired in the
Both sides or one side?
in the BIP joint. What we will do next?
I will continue. I will continue on the proximal, then on the rest. Up to which level?
Up to the wrist.
Okay, both sides the same.
Yes.
Okay, I will ask for checking the gait of the patient.
Okay.
What is any specific gait?
Spastic gait.
Spastic gait. Okay. I will ask
Sorry,
permission to
spastic ataxic gait.
I will ask permission to check any Piscavas.
No, there is no Piscavas.
I will take permission to check
1 minute
cranial
left.
nerve. Okay, 5 and 7 and 8. What about them?
Normal.
Uh,
What?
I
I
will
cannot
complete
hear you.
I will complete the sensory by crude touch in a differential.
What?
Crude touch.
No, nothing.
Okay, and vibration, same level.
Vibration, yes.
Up
It's
to rest.
affected. Yes.
Okay. Still time, Dr. Basim? Thank you.
Yeah, 6 seconds. What you have to do? Okay, time is up. What do you want to do or to say? Dr. Muhammad, your internet is breaking again.
You are hearing me, Dr. Basim, now?
Yes, okay. What you want to do or to say now?
خلاص Dr. Basim, I am collecting my thoughts.
Could you present your case, please?
Okay, we have a 43-year-old female came complaining with witness by general inspection. There is cervical collar. There is by inspection by examination. There is bilateral spastic varices in picture of in pyramidal shape, spastic varices by side with the loss of posterior column sensation in picture of vibration and joint position up to the wrist level. There is a spastic gait appearance and no sign of no scar behind the back of the neck, no atrophy, no articulation. The weakness more distal than proximal. There is absence of biceps reflex and accelerated triceps with both pathological reflexes, sign and inverted reflex. By collecting all of this, my first diagnosis, cervical myopathy, trauma, transverse myelitis, disc prolapse,
Okay. Are you done?
Okay, so cervical myopathy due to trauma, trauma, disc prolapse, tumor, also maybe infection like TB. Okay.
Okay. What type of lesion that this patient has? He has features of pure upper motor neuron lesions.
He has upper motor neuron lesion with posterior column lesion also affected.
Okay. So, what do you think the level of the lesion is?
The level of the lesion will be in view of absent biceps. It will C5, C7.
Okay. Isn't the absent biceps a feature of lower motor neuron lesion?
Absent biceps, it is at the level of the lesion can be a loss of the give a picture of lower motor. but in presence of the exaggerated triceps, which is the level of C8, so there is sensory level there. It will give this appearance of mixed.
Okay, so now you have a mixed picture, right?
Yes.
So what is your differential for a mixed picture in the upper limbs?
My first is cervical myopathy.
What else?
I mentioned infections like tabes dorsalis,
Okay, what else?
subacute combined generation,
Okay, okay, what are the causes of cervical myelopathy?
maybe disc prolapse, maybe tumor, maybe trauma, maybe surgery.
Okay, what is the most common cause in elderly patients?
In elderly, it will be a degenerative spilo.
Spondylosis. Yes, that's right. How are you going to investigate this patient?
I will do emergent MRI for his cervical spine, rule out
Okay,
any compression for any urgent decompression surgeries, and apart from a basic is CBC and inflammatory marker is CCR, and I will do nerve conduction velocity for both upper limb, and I will send for vitamin B levels. I will do also
okay. What do you expect to find in this patient lower limbs?
in patient lower limb.
Yes.
It will be also pyramidal shape, mixed shape, the same will be spastic paraparesis.
Okay. So why do you think that this patient has a spastic ataxic gait?
Spastic ataxic gait. This mean affection of cerebellar also. So maybe the patient has MS also or old cerebellar stroke.
Okay. So how are you going to manage this patient?
By multidisciplinary approach, I will involve the neuro and surgery team, occupational and social health, and as I mentioned, after doing spine, we'll decide the surgery or medical. As he bought this cervical collar, it will be fixed according to the advice of the neuro team. After checking the vitamin D levels, maybe need replacement. We'll do also MRI brain to rule out all the stroke, and MRI spine for MS and to rule out MS. We can do also lumbar puncture for origoconal glands and
Okay, that's enough. Thank you very much, doctor.
Okay, thank you, Dr. Kotov. Can you comment now?
Okay, so doctor, just to start, you forgot some things in the examination. You did not check for the pronator drift. You did not check for pseudoathetosis. At first, you have to ask the patient to stretch her hands to check if there is tremor. Then you have to check if there is pronator drift or no, if there is pseudoathetosis or no. What do you expect in this patient regarding the pronator drift and pseudoathetosis? Both of them will be positive, but this patient has extra pyramidal shape of weakness, and she has also sensory ataxia, features of sensory ataxia. So the pseudoathetosis and pronator drift, both of them are positive, but you didn't check for them. And when you were presenting the case, you didn't mention that this is mixed sign. You just presented this as pure upper motor neuron lesions, but you have absent biceps reflex. So this is actually a mixed upper and lower motor neurons features with positive dorsal column affection. And regarding the other discussion questions, the main segment affected will mostly be the C5, C6 because of the absent biceps reflex. As you mentioned, it will be lower motor neuron signs at the site of the lesion. So the biceps reflex is the absent one. So it will be C5, C6 because this is a vertebral level of the biceps reflex, the spinal level. So and regarding the lower limbs will be pure upper motor neuron lesions with possible dorsal column affection. It will not be mixed as in the upper limbs because as we mentioned, it will be lower motor neuron lesion only in the site of the lesion. Okay, and what else? Regarding the investigations, you should start by offering general investigations, and then you cannot jump directly to the MRI. You can start by simple imaging, like just like a cervical X-ray, for example, and then you can mention the cervical MRI as a gold standard of this condition. Yes, the causes are degenerative tumors, trauma, disc bulging. And the management, as you mentioned, it should be multidisciplinary team, physiotherapy, occupational therapy, and you have to treat the symptoms. And you have to do DVT prophylaxis because this patient might be bedridden. And then pharmacological treatment, we can go for simple analgesia, steroids, or even nerve blocking. And the definitive therapy is surgical intervention for sure. That's all I got. And regarding the supinator reflex, I told you that the fingers were the thumb and index were flexed. This is inverted supinator reflex, and it's common with the cervical myelopathy, as well as Hoffman sign. That's it.
Okay, thank you, Dr. Gutov. What do you think about pronator drift? You said it would be positive? Pronator drift.
Yeah, I think it will be positive, I guess.
I don't know. I'm not sure. It's supposed to be negative because this is lower at the level and upper below the level, right?
Yeah, it's below the level, so I guess it should be
Hello?
yes, it should be positive.
أهلا كيفك؟
So the pronator
عشيت في
muscle.
البيت.
Sorry. Wait.
سلامتك شكرا.
Okay, so the pronator muscle supplied by less or lower than C6, you mean?
I
The
think so.
pronator? Okay, I'm not sure as well. But let's talk about the lesion, as you said, or the differential or the case itself. So on top of them, as you said, degenerative cervical myelopathy, right? The level at the level, so you will have lower motor neuron lesion at the level. So C5 and C6, which is biceps, will be lost. And the other below the level will be upper motor neuron lesion.
Yes.
We'll talk about the muscle wasting in the hand. Did you mention it?
No, because if there is muscle wasting, the lesion would be much lower, like C7 to T1, for example. So because, wasting of the hand muscles is the lower motor neuron sign. So if the
Yeah.
lesion was in C7 to T1, for example, they will be wasting,
Okay.
but not in this.
Yeah. What about syringomyelia? Is it differential in this scenario?
Yes, it's one of the differentials in this
Yeah.
scenario. The differentials will be the causes of mixed upper and lower motor neuron lesions, such as syringomyelia will be on the top of the differential in this case.
And the other cause of
Sensory
cervical myelopathy.
Yes, the sensory affection, and it could be what else?
The other cause of cervical myelopathy,
Yes.
the underlying cause.
Syringomyelia will be one of the top differentials in this case.
Yes, okay. I think we discussed most of the important differential here, but I will add to my comment, Dr. Muhammad, whenever you are presenting a patient a nervous station particularly, try to say and to describe the lesion, not to give diagnosis. So you will say this patient is having mixed picture of upper and lower motor neuron lesion. And you can say where is the lower and where is the level of upper. So we'll say hypotonia, hyporeflexia at the level of C5. I can find it in the biceps and the muscles in this area, supplied by this area. And so hypotonia, hyporeflexia in the level of biceps. Okay. And in the other part of the hand examination, I found hypertonia, hyperreflexia in the form. This is an upper motor neural lesion feature. So you have both of them, upper motor and lower motor neural lesion features. So collecting this finding together, this is as motor and reflex and tone. So tone, power, and reflex. Coordination intact or impaired, as in this scenario, I don't know. Was it impaired, Dr. Gotov?
No, it was intact.
Because you said there is ataxia.
Yes, but
That's why دكتورة كوتوف
reflect the cerebellar, huh?
that's why يعني it should mention for me or me ask you the patient attacks it opening eye or closing eye to confirm
Yes.
this
Yes, yes, but you didn't ask.
yes.
You just checked for cerebellar like nose to finger nose test. It was
No,
normal.
but usually the patient during
Even,
walking
yes.
and in ataxic it will be cerebellar. Should
Yeah,
be finger
when the
nose
patient is
positive.
closing his eyes, you have to check
No,
for
no,
it.
closing his eye. I will
No,
ask
no.
Romberg test. I think.
Yes.
Yeah, but
If
this patient has no cerebellar affection. It's intact.
Dr. Gotov, let's clarify it. Whenever you have less of coordination when the patient opening his eyes, this is cerebellar.
Yes.
Okay? So you mentioned like that. So we cannot assume there is cerebellar affection here. Even the walking, it will be intact. Right? It will not be ataxic.
No, but he has sensory ataxia in this case.
Sensory ataxia, so you will do the Romberg to confirm it.
Mm.
You got it?
Yes.
The patient depending on two things while walking, the eyes and the cerebellum.
Yes.
That's why
So-
Dr. Bassem, I asked about base cavas because I thought خلاص I go to the Fredericks plus cervical myopathy. That's why I thought this.
Okay. Yeah, I agree. So there will not be any cerebellar if you don't have any cerebellar syndrome. So everything will be intact. The coordination, even though the gait will be intact. What will be impaired as the column, the Romberg test. Okay? The patient will not have ataxic gait if he has sensory ataxia. You got it, Dr. Bit.
معلي تضيف confusing point بهالنقطة.
But in English,
الصراحة
please, Dr. Bit.
practical wise sensory ataxia, if it is severe affection of the dorsal column,
Yes.
the symptoms will be the patient when he's doing finger nose test, you will be in doubt. The patient will do it, يعني let's say it's not perfectly, and when he close his eyes,
Now it
the
appears more.
ataxia increase. You are right.
Yes.
So sensory ataxia whenever the dorsal column, especially when it is central. طبعا كلامك بينطبق 100% على البريفرال cause of sensory ataxia. صعب انه البيشنت finger nose يكون abnormal والاي open، لكن لما بيكون central which is between two brackets dorsal column ممكن اثناء ما عم يعمل finger nose يعني you feel it is not the
Not
best.
accurate. Yes.
It's not accurate. And when you ask him to close his eyes,
It will
now
appear.
you get to know that this is because of sensory ataxia. So the symptoms will worsen more and his dysmetria and pass pointing will become more obvious. ونفس الشيء ينطبق على الموفمنت الجيت آسفة. When he is walking, you will feel a dorsal column patient who have dorsal column affection. He's not walking very well. He will not be able to do tandem gait حتى مع انه his eyes are open. When you do Romberg test in eye closed, you will feel a worsening balance. He cannot at all maintain his posture. Whenever there is a dorsal column practically wise، هلا ممكن نحن نعمل الكيسز to help each other، بس in the exam لو جابوا لي patient و I had such a feature و I am prepared I might pick up a dorsal column وما بلخبط بينه وبين السيربيلم، لأني أنا وقت قلت له للبيشنت غمض عيونك close your eyes the dysmetria worsen. بالإضافة لما يعني when you look at his speech normal speech non-nystagmus تمام. you will find السيربيلم يعني شلون بدي اقول لك you will be in doubt. You will be in doubt about the cerebellum. what will explain better those signs الsensory ataxia تمام. especially لو اجت معها كمان vibration و proprioception affection حتحلف انت وقتها انه هالديسمتريا اكثر related للسنسوري ataxia من السيربيلم.
Yes.
تمام. مع upper motor neuron حتقول لا خلاص معناتها هذا dorsal column affection part of myelopathy اللي هو spinal cord affection. تمام. فهي
Yes.
بقى let's say الاوفرلاب او difficulties in this issue. بس نحن فعلا جرت علينا العادة انه to keep sensory ataxia normal while eyes are open. انا اجري، انا ما بقول انتوا غلط، بس جرت العادة بهالطريقة. لكن is this practically او if we have a real neurological cases applicable لا ممكن تلاقي فيه variabilities.
Okay. Clear now.
Yes, and doctor, it's common in patients with cervical myelopathy to have ataxic gait due to the severe dorsal column affection.
dorsal column affection. Actually,
Yes.
I agree with you.
Yes.
يعني أنا بصراحة اللي
One of
خلاني
the characteristics.
إنه usually you find the patient having وبتعرفوا ليش السرنجوميليا يعتبر differential رائع؟ لأنه السرنجوميليا بيعمل لك بط كياري، والبط كياري بيضرب لك السيربيلم بسبب البروتروجن.
Yes.
تعطيك wide ataxic gait you might really mix both of them. بس بالcervical myelopathy it's a dorsal column you have a proprioception vibration affection, while in syringomyelia you will have a butt chiari with full blown cerebellar syndrome picture. فكتير حلوين كتو differential for each other.
Yes,
تمام.
and the Romberg test, he didn't ask for it in this case.
هلا I agree رومبرغ تيست إذا هو ما سأل عنه هذا against الكونسبت اللي جرت عليها العادة. لأنه جرت العادة إنه نعمل الرومبرغ تيست to make sure it is not sensory ataxia.
Yes.
بس مع هيك يا جماعة positive رومبرغ test can be for central sensory ataxia between two brackets dorsal column or peripheral sensory ataxia between two brackets اللارج فايبر النيوروباثي اللي هن مين الديب سنسيشن البروبريوسبشن والفايبريشن. فالرومبرغ تيست is helpful for to make sure it is not cerebellum for example. مع انه لو وقف هو البيشنت وقف وقرب رجليه على بعض و immediately he become ataxic لسه ما غمض عيونه actually cerebellum will be part of our differential until we exclude. تمام.
Yes.
فللأسف الرومبرغ يعني if it is like when he stand و close his legs together everything is fine, then when he closed his eye he become ataxic. اوكي يا sensory central يا sensory peripheral. طيب لو بس قرب رجليه على بعض ولسه عيونه مفتوحة ممكن نقول cerebellum versus central sensory ataxia. both of them can be still a differential. وطبعا لو كانت central sensory ataxia when he will close his eyes to complete the Romberg test he will become more ataxic. لكن never do it. لو البيشنت at the time when he close his legs together he become ataxic it will be against the welfare انك تكمل التست وتقول له غمض عيونك. ما عاد صفي عندك غير you have
Yes.
one chance to confirm الفينجر nose while eye closed بس مو الرومبرغ test while eye closed لأنه الويلفير will be affected. فإذا البيشنت my patient closed his legs his eyes open he get ataxic I have to keep in my mind to confirm this by finger nose test while eye closed I have to abort a Romberg test let the examiner know that for the welfare I will not ask the patient to close his eyes even though I'm expecting it might worse.
Yes.
أو take a permission of the examiner.
And always,
بس
yeah,
take
always
care
be beside.
take care not to go on يعني. تمام.
Yeah, in all situations you have to be next to the patient, very near, in order not.
Yes, especially إذا أنت female وهو ما شاء الله عليه large patient be very careful be very careful. ويفضل إنه تنعمل عن جد يعني يا الحيط وراه يا السرير
Okay.
وراه
Yeah, exactly. Near to the bed, yes. Yeah.
or near to the wall. يعني anything to support him if he لا سمح الله fell backward.
Okay.
تمام.
Yes. Thank you, Dr. Hind. It's a very nice point and doubt clear now, I think, for all. So, Dr. Hind, you mentioned bad Kayari. I think it's called the Kayari only. Kayari
أرنولد
syndrome.
كياري آسفة مو فت
Okay.
كياري أرنولد كياري دي
Okay.
malformation أرنولد كياري.
Yes. Yeah, okay.
الله يساعدك يا رب شكرا.
It's okay, Doctor. No worry. Any question, Dr. Muhammad or Dr. Gotov? I think the investigation mentioned yes, but I don't think here you can do nerve conduction study because it's not peripheral, Dr. Muhammad. You mentioned nerve conduction study. Okay, it's something central. So what you have to do here, all investigation and image to be central, like brain or spinal cord, particularly the spinal cord. The good thing here also, you comment, I want to look at his neck, at the back of his neck. Sometimes they have previous surgery and again it works. Okay. Other investigation, if you mention the vitamin, the anemia, other workup as general, but the most diagnostic tool here will be MRI spinal cord, particularly the level of C5 and C6 as you mentioned.
ولا ننسى كمان دائما وقت بيكون في عنا myelopathy irrespective of the cause always exclude the reversible causes the correctable causes of myelopathy اللي هي الفيرال serology لأنه لو كانت transverse myelitis you will
Yes.
treat the underlying cause you will solve the issue تمام وانت you can have
Multiple.
transverse myelitis at the level of the cervical even though it's not too much common but keep in your mind to exclude in your investigation reversible causes لأنه ال MRI in these reversible causes unfortunately can be normal فلو هو مثلا vitamin B12 copper vitamin E deficiency okay those elements which can be corrected or supplements which can be corrected it might give you normal MRI so before you say MRI say I would like to run a panel for the reversible causes include vitamin E level, vitamin B12 level, copper test وممكن الفيرال PCR serology whatsoever according يعني just exclude infection especially الفيروسز herpes zoster HIV human T lymphocyte تمام فكلياتهم هدول ممكن يعملوا لنا myelopathy agree انه predominant motor في جزء منهم مثل الهيومن ليمفوسايت لكن please exclude الانفكشن especially viruses والبي 12 والكبر والفيتامين E before you jump on to MRI.
Yes. And what about NMO and multiple sclerosis as a differential? Is it possible to have multiple sclerosis with lower motor, or all of them will be upper motor neural lesion?
عادة ال NMO والمالتيبل سكليروسيس
As a cause of
describe إنه it will affect بس since it is not cutting أو يعني the way it affect a selective tract
areas.
أيوة
Yes.
فبتعمل mainly upper motor neuron lesion in the area بس ال affected أما عندك ال compressive causes هي اللي بتعمل حركة lower motor at the level
Yes.
و upper motor below
Yeah.
الكompression below الديفكت لكن اللي بتجي selective وبتاخد segment ما بتعمل compression مشان هيك بنسميها non compressive causes صعب تعمل الميكست تمام
Yes.
لانه بتاخد جزء بتأذيه وانتهى الموضوع اما الكومبريسيف لا بتضغط على مكان وبتضرب التراكتس تحت هالمكان اللي انعمل فيه compression تمام فit will lead to mixed فيوجوالي الكومبريسيف it follow the mixed concept الcompressive causes of myelopathy لكن ال non-compressive causes of myelopathy it depend usually it is upper motor neuron لأنه عادة we mention for non-compressive transverse myelitis وما أوسع الكوزز تبع الترانسفيرس myelitis بما فيها ال MS وال NMO لأنه ال NMS وال NMO جزء من الترانسفيرس myelitis
Yes.
تمام this is يعني this is how it usually go when you give myelopathy وmy advice whenever you find bilateral symptoms is a bilateral lower motor neuron disease خلص peripheral neuropathy until proven otherwise is a bilateral upper motor neuron disease myelopathy until proven otherwise myelopathy between two brackets spastic paraparesis تمام اوكي
Yes.
فاذا انت لانه اغلب الاحيان they love the term myelopathy or spastic paraparesis for differential diagnosis then he will continue with you wherever he want to go او you will continue based on the additional feature بقى myelopathy with dorsal column myelopathy sparing the dorsal column myelopathy with all four modality affection تمام this is how you will differentiate ويعني I notice إنه myelopathy term is more favorable than spastic paraparesis تمام لأنه it's localizing term while spastic paraparesis is the clinical picture
Yes.
تمام
Yes. Okay. Thank you, Dr. Hind.
almost
Yeah, let's read the comment quickly. Dr. Gotov, be ready for your scenario. We will start in a while. Yes, it's Arnold Chiari syndrome, not bad. Yes, we already corrected that. Doctor asked to assess gait only. The Romberg test should be offered as you are suspecting affection level below the cerebellum. Yes, I agree for this. Does syrinx affect posterior column? Yes, in advanced stage, it can affect the posterior. So it started with the anterior initially, and if it's increase of the herniation and the fluid collection, accumulation, it will also affect the dorsal column. How do you test for pseudoacytosis, Dr. Ines? Is it important? So, Dr. Gotov, how to assess for, I'm not sure about it. Pseudoacytosis, how to do it? Pseudoacytosis in upper limb equal to Romberg test. Is it important to do pseudoacytosis in exam? MS, I think it will not be bilateral symmetrical if spinal cord affection, if I'm right. Yes, supposed to be asymmetrical, or it can be also symmetrical if. So it's not a rule to be symmetrical or asymmetrical, but commonly it will be asymmetrical. Dr. Hind, if you are there, you can tell us about pseudoacytosis.
Pseudoacytosis is actually, unfortunately, أنا لاحظت إنه past test is really too much concentrating on it. And it is valuable because if you notice, we don't have an equivalent of Romberg test in upper limb. And if you have an upper limb examination station, you will not be able to ask the patient to stand and do Romberg test. So it is very valuable. Hoffman sign, an equivalent of plantar, and pseudoacytosis an equivalent of ASFA إلا plantar والpseudoacytosis equivalent of الرomberg. يعني it make too much sense to do it لأنه again pseudoacytosis can be positive in sensory ataxia related للcentral cause which is dorsal column or related it is more with the central cause يعني it is more significant in the central cause which is the dorsal column comparing the peripheral neuropathy because in peripheral neuropathy we have vibration proprioception so pseudoacytosis usually add some kind of value to our examination and to our differentiate. A second step how to do it always when you ask the patient to outstretch his hand there is two steps. First, outstretch the hand in a pronation position and ask the patient to close his eyes. If his hand or wrist, to be more specific, plus the fingers start to move in a wavy pattern while his eyes are closed, سواء مثل ما اتفقنا الإيد كاملة بما فيها الرست or the fingers start to go up and down as if it's really drawing a wave. Okay, while eyes are closed, this is a positive pseudoacytosis. تمام. Then you will ask the patient at the same position while he's outstretching his hands to switch or flip his hand into supination. And ask the patient to close his eyes in order to test for pronator drift.
Pronator drift, yes.
تمام. ولا ننسى كمان إنه أثناء ما هو مسكر عينه while he's closing his eyes and while you are testing for pseudoacytosis, there is another sign which could start to appear, which is which sign?
Finger, you mean?
Finger split sign. Little finger split sign. فجأة you will find that the little finger is swapping away from the hand.
Okay.
يعني as if it's like falling ولا separating ولا يعني somehow. Okay. it is because of the weak adduction. تمام؟ weak adduction. طبعا هي الساين is more significant when cervical myelopathy is affecting C8T1. تمام؟ لأنه C8 و T1 are the roots responsible for finger adduction. But some people they are saying that it can happen even with cervical myelopathy at any level. تمام؟
Okay. Yes. Thank you,
So
Dr.
it's
Hind.
also happening while eyes are closed.
Okay, it's clear. I think it's also more advanced than PACES exam. I don't think they can.
It is more advanced. الفينجر split sign قصدك ولا السودوأثيتوسيس؟
No, no, the finger split or just.
فينجر سبلات موجودة بويستي بس يعني at least I agree with you لأنه ما كانت يعني past test even when they did a cervical myopathy they didn't discuss it but it is there in our books يعني it is mentioned بس at least it is important also بالulnar neuropathy.
Yes,
The
yes.
same concept بس if you forget it no issues but for pseudoathetosis take care of it يعني we can include it in our scheme. It deserves صراحة.
Okay, thank you, Dr. Hind. Let's move to the next scenario. Dr. Kutuf, you ready?
Yes, doctor.
The instruction, you are examining Mr. Farouk. He is 35 years old, presented with a complaint of fatigue. Examine his abdomen. Here you go.
Should I start immediately? Hello,
Yes.
my name is Dr. Abdussalam. I'm one of the doctors in the exam today. Are you Mr. Farouk?
Yes.
I want to examine your tummy, if that's okay with you. Yeah, during my examination, if you feel any pain or discomfort, just please let me know so I shall stop.
Okay.
Okay, I will take 2 steps back. I will check if there is anything in the surroundings, in IV cannula, anything.
No.
Okay, then I will come closer to the patient. I will make sure that the patient is exposed. I will start by looking at his fingers. There is any clumping or leukonychia?
Picture, Dr. Basim.
Yes, I will share the picture now of the hand.
Okay. Can you pause, please, the timer?
Here it is. Okay, you can see it in the chat box.
Oh,
I will pause the timer, yes.
it's not very clear.
No
Um,
clubbing.
But the fingers are not very clear. The nails.
What you ask, tell me what you want, I will tell you.
Okay,
There is no
continue.
clapping.
What?
No clapping.
No clubbing.
No leukonychia. There is
Mild
something
leukonychia.
like subangle, mild leukonychia. There is anything below the nail like subangle fibroma or onycholysis or something?
Little anecholysis.
Little onycholysis. There is any pigmentation or swelling of the fingers?
Little swelled, deformed.
There is some dactylitis. Okay. Then I will check the palm. There is any palmar erythema
No.
or pituitary contracture?
No.
I will check the pulse. Normal.
80.
Normal volume.
Sorry, 100.
Yes.
Hyperdynamic.
Okay. Then I will ask the patient to outstretch his hands. Any tumor?
Second picture, Dr. Basim. Can open the picture, Doctor.
Okay.
Is it clear?
It's not very clear. I can see there is a fistula in his arm.
Okay, so continue.
Open the picture, Doctor. It will be very clear. Open the picture. يعني spread it. You can see the hand, the arm, the abdomen.
Okay, okay.
Continue.
Okay, so there is any fine tremor or flapping tremors?
Yes, there is a fine tremor.
Okay, no flapping tremor.
No.
Okay, so I can see a fistula in the right arm. There is any recent needle marks?
Yes.
Okay, any signs of infection?
No.
Okay, there is thrill,
Yes.
a bruise.
Yes.
Okay, then I will go check if there is below the axilla an axillary hair.
Yes.
Okay. Then I will go to the eye. There is pallor or jaundice.
Mild pallor.
Okay. I will check the mouth. There is any gingival hyperplasia,
No.
mouth ulcers, central cyanosis. Okay, there is a temporalis muscle wasting or parotid enlargement.
No.
Any raised JVP,
Mild raised GVP.
mild raised. Okay. I will check if there is any gynecomastia or spider nevi.
No.
Okay, I will put the bed flat and start by superficial palpation. No, I will just first go to the end of the bed and ask the patient to take a deep breath. Any
Yes.
change in contour?
He's in front of you, Doctor.
Okay,
Both
okay,
flank is bulky and there is some bulging there.
okay. There is any, I will ask the patient to cough. No, any hernia.
No hernia.
Okay, no lower lymphedema.
Mild lower limb edema.
Okay, I will start by the superficial palpation. Any superficial masses or tenderness?
Left side, there is mass tender. 4
In the left
centimeter
side?
in 6 centimeter.
Where
Left side.
exactly? In the lower
Left side.
part?
Yes.
In the lower iliac fossa?
Yes.
Tender?
Yes.
Okay. Then I will do the deep palpation. Any hepatomegaly below the costal margin?
No.
Okay, how much is the liver span by percussion?
Average 6 to 7 centimeter.
Okay. What about the spleen? There is splenomegaly below the costal
How you
margin.
examine?
What?
How you will examine?
I will do deep palpation and go diagonally from the right iliac fossa up to the left costal margin.
Okay. What about the mass?
1 minute left.
There is no splenomegaly.
No splenomegaly.
Okay, I will tilt the patient and to make sure. Still no splenomegaly.
Yes. No.
Okay. Then I will do shifting dullness for the ascites. No, I will examine the mass first in the left lower iliac fossa. There is any scar underlying this mass? I cannot see clearly.
Yes. There is a scar.
There is a scar. Okay, I will examine. You said it's tender. Is it dull or percussion or resonant?
Dull,
4
tender,
centimeter.
4 and 6 centimeters.
Okay, there is ascites or no?
Mild ascites. There is
Okay.
positive.
Okay, in the renal pallotomy, there is felt kidneys or no?
Right side, there is palatable kidney.
Okay, left side,
Not
Not-
sense.
not felt. Okay, so there is. I will auscultate any renal bruit.
Renal bruit?
Yes.
No.
Over the mass.
No.
Okay.
Okay. So there is any bowel sounds.
Time is almost up. Yeah, time is
Okay,
up.
then I will check for the back for basal crackles.
Okay. What else in the
What?
there is crackers?
There is some fine rails basal.
Yeah, okay, there is crackers. Okay. Dr.
Okay.
Kutuf, the last question. What you want to examine at the back quickly?
In the back, I will examine for basic crackles, sacral edema, and lymphadenopathy, cervical and supraclavicular.
Back. At the back. Inspection.
Inspection of the back.
Anything important at the back? Okay. Examiner question, Dr. Muhammad.
Okay, Doctor, present your positive finding.
Okay, I have examined Mr. Farouk. He is 35 years old. Man complained of fatigue. On examination, he has, in his nails, he has onycholysis with the dactylitis. And he has a fistula in the left side of his arm with functioning fistula with bruit and thrill and recent use needle marks. And he has pallor. And on his abdomen exam, he has left iliac fossa scar. Underlying this scar, there is a tender mass 4 centimeters in diameter, and he has a palatable right mass resonant or percussion, most likely the kidney. And he has signs of overload manifested by ascites and lower limb edema. I think there was no ascites. There is a mild lower limb edema and basal crepitations. In conclusion, I believe that this patient has a case of chronic kidney disease. His current mode of replacement is fistula, in the functioning fistula in his right arm. His previous mode of replacement was a transplanted kidney, which is most probably not functioning now, and it's tender at the moment. Okay, and based on the right kidney, this is palatable. It can be one of the polycystic kidneys, and he has features now of overload, but there is no features of drug toxicity.
No, there is fine tremors, Doctor, I mentioned.
Yes, there is fine tremors. There is some features of medication toxicity manifested by fine tremors, but there is no gingival hyperplasia.
There is also thin skin.
What?
Thin skin.
Thin skin?
Yes.
I cannot notice any thin skin.
No, I am mentioned to you. You will
You
feel
are
thin skin. Also,
there
there
is
is
thin skin.
toxicity, right?
So you're asking about the possible cause of the kidney failure?
No, I finished your presentation.
Oh, okay. There is thin skin as well. Okay.
Finish the presentation.
Okay, and I think I measured all.
خلاص, you mentioned the positive finding and the last two modes is a kidney failure.
Yes, I couldn't. There is also shrunken liver, 6 centimeters in diameter, but there is
normal. I mean
there's-
normal.
what?
Normal. 8 centimeters. It is normal.
You said 6.
Sorry for this. It is normal.
Okay.
Don't be.
So I couldn't appreciate any features of chronic liver disease or jaundice or lymphadenopathy. And I would like to complete my examination by obtaining full set of observation and a urine dipstick.
Now you mentioned the failure of the kidney transplant. This is the last mode, and the new mode is through fistula, and it
Yes.
is functionally and recently used. Can you tell me, and the past, the cause of kidney transplant, you mentioned polycystic kidney, right?
Yes.
In this age, any other causes can be?
It could be connective tissue disease. And the patient has dactylitis and onycholysis. He might have psoriasis.
Okay.
But
Regarding the hand, if I told you this deformed bone, what does it mean for you?
or it could be rheumatoid arthritis, for example.
Or a complication of chronic kidney?
What?
A complication of CKD?
Yeah, it could be dystrophy.
Renal dystrophy.
Yes.
You need to see any neck, in the neck, you mentioned lymph node, any other thing to search for it in CKD
Yes,
patient?
I can search for any permacath, for example. Either current permacath or scar.
Yes, scar for what?
For permacath.
Any
Or
other scar you can search? With this renal dystrophy?
it could be parathyroidectomy.
The scar for parasubirectomy there.
Yes.
Now, what is the cause of tender masses?
It could be infected transplant, for example, or thrombosis.
Yes. Other
What?
causes?
Thrombosis, infection, trauma, hemorrhage.
Yes. Rejection?
Yeah, the rejection itself.
Yes. So, what you would do for this patient?
Okay, this patient now needs admission because he's showing signs of overload. He can be in acute kidney injury right now. And I need to admit this patient. We will start for him, we'll do for him investigations. He might need dialysis because of the overload he has now. I will start by doing for him basic investigations. What?
Yes. What investigation is?
I will start by basic investigations like full blood count, kidney function test, urea electrolytes. I will also do liver function test. And then I
What
will do
electrolyte? Specify electrolytes, please.
I can do sodium, potassium. Most importantly, we have to check the potassium if he is hyperkalemic, and we have to check the ECG as well. And we have to check for uremia and other features of uremia.
What about calcium?
Yes, we have to check the calcium as well. He could be hypocalcemic.
Yes. Okay. Continue another investigation.
Okay, then I will do for him abdominal ultrasound. I can do also urine analysis to check if there is infection. I can also send for a blood culture in cases of infection, and the ultrasound as well can show if there is hemorrhage or trauma. And then we can even proceed to CT abdomen. Then I will investigate for the underlying cause. I will send for rheumatological panel autoimmune screening. And CT scan as well if the case is polycystic kidney disease. And
Regarding rejection,
regarding rejection, we can, if there is, we can do function test, kidney function test. We can do renal biopsy, and we can do Doppler to see if there is thrombosis. Okay, and then we will search for the complication. For the complications are uremia. I will do chest X-ray to check for heart failure and pulmonary edema. Then I will check for drug level for the toxicity because the patient already has fine tremors.
okay, I told you this patient has headache also. Does it make sense for you?
Yes, if the case was polycystic kidney disease, this patient is at risk of developing berry aneurysm. It could be subarachnoid hemorrhage or simple hypertension because they are at risk of hypertension as well.
What you will do for him?
If this patient has headache, at first I will check his blood pressure. Then I will send for him urgent CT scan and a lumbar puncture to check if he has a subarachnoid hemorrhage or no, and also MRI brain.
Yes, MRI, MRA, MRV, right. Okay, دكتورة. So, thank you. خلاص, finish my question.
Okay, thank you.
Okay, thank you, Dr. Muhammad. You can comment now.
Very well, mashallah. Only the examination little delayed for lymph node scars in the neck. She go to the mass and pass it, then come back to it. Once you see the mass, خلاص, you will examine size, and you can palpate it. You can get not moving with respiration. It is tender. Then you continue. Yes, palatable kidney, catch it. The sign of current mood and previous function. And despite he is in the current mode, he has sign of overload. So he is there is must be a review for his dialysis schedule. How much yeah, there is some non-functional or inaccurate any schedule for his dialysis. That's why he's overload, or his diet by history. Yeah, he need to the management about his dialysis and his current diet. Tender graft you mentioned, right? They may be infection. First one, rejection, then infection, maybe trauma. In the rejection, the causes may be renal venous thrombosis, renal artery stenosis, ureter problem, leakage stricture. Then during your examination, or even during the examiner, you can tell, I have seen this sign of tachyplemus toxicity in form of tremors. and I didn't found any other sign like skin masses like the lymphoma or Kaposi or you mentioned no gum hypertrophy, no excessive hair, no for the steroid. يعني you give a hint about the drugs adverse effect or complication. For full indication for the transplantation in young patient, here we found the polycystic kidney. For the young, the other, he has, as you mentioned, also some autoimmune like lupus, some nephritis, recurrent reflux nephropathy, NSAID nephropathy, maybe genetic, other genetic like Albert or like this. And in old age, if the patient old age, diabetes and hypertension, you will find break in his needle break in his fingers, and he will bring his blood pressure too much high. Okay, you mentioned most of this. I am only revising with you. For the hand, this renal dystrophy, you need to have some X-ray for hand also. You will confirm your maybe as you mentioned psoriasis or rheumatoid or as a complication of CKD. Serum calcium is very important in parasyroidectomy. Maybe he's also causing his fatigue. And okay. That's all, Dr. Basim. Renal Doppler طبعا is very important. Renal Doppler for the any graft rejection, for thrombosis or stenosis. This is very important for any malfunctional graft or liver graft. Okay.
Yes, thank you. Perfect, Dr. Muhammad. Good presentation of the case as abdominal polycystic kidney and transplanted one, complicated by rejection or infection. And always remember the recurrence, okay? Don't forget. 3 of them: infection, rejection, and recurrence of the main disease or original disease. Then the current mode, AV fistula, as you mentioned. I will ask now Dr. Kotov why I ask you to inspect the back. What do you think the important in the back to find out related to the case? Okay, in another way, where is the left kidney?
Uh-huh. The left kidney might, I think they might take it out, maybe?
Yeah, so how to know it? Is
Maybe
it
there's
out?
a scar.
Yeah, so you have to check the back for a scar.
Yeah, because I know sometimes in polycystic kidney they have to remove one of the kidneys to make room
Exactly.
for the original, for the new one.
Yeah, this is my question earlier. Why, what to inspect at the back? It was for the nephrectomy scar. Okay.
Okay.
Yeah, because you felt the right, but you
Nice.
didn't feel the left. Where is it? So it could be removed, and you have to find the nephrectomy scar. Okay, I will ask one more question. What if you have anuculitis and you suspect there is psoriasis or rheumatoid? What do you think the cause of renal failure will be?
In rheumatoid, for example, it could be like membranous
Okay,
glomerulonephritis, or it could be due to amyloidosis, or it
perfect.
could be due to other causes of glomerulonephritis or vasculitis.
Okay, what else? If we say
Could be due to medication, for example, NSAIDs,
yes,
analgesic
perfect.
nephropathy.
Yeah, so analgesic nephropathy one could be also one of the causes.
Yes.
As related to the main disease, psoriatic, for example, or rheumatoid arthritis. You don't know what the reason, but you can give a lot of differential. So to be honest, during presentation, the examiner will not give you 2 minutes to present your case. It's 1 minute for presentation, okay? 1 minute for the differential, 1 minute for the investigation, and the last minute for management. So either to be concise, don't mention the negative thing, or try to mention the most important positive finding related to the case. Yes, you can start with the hand. Sometimes they are skipping. They are telling, give me the most important. So what is the most important finding in this scenario? You can mention earlier. If he skip the peripheral.
It will be the fistula and the kidney,
Perfect.
the transplanted
Exactly.
kidney.
Yeah, so tender mass with a scar underlying tender kidney, it's moving or not moving. Is it hard inconsistency, so you have to talk about it or to describe it quickly. Then, as you said, the signs of volume overload, the current mode of dialysis, and the previous mode. Lastly, the complication of medication, as you said. Try to make them in 1 minute. Train on that because they will not give you a chance to think.
Okay.
They might interrupt you even to ask for other skills. Differential, he has to ask you about differential diagnosis. Why
Yes.
this kidney or the transplanted is tender. So you can say, as I mentioned, the infection and re-
Thrombosis.
rejection, or infection or recurrence of the main disease. The details, yes, like thrombosis, it could be thrombosis means also rejection.
Yes.
So be more categorized in the answers. Start by the main causes. Then you can say the other cause like thrombosis, and he will ask and he will guide you to the point he wants. For example, if he want to know that there is thrombosis, he will tell you how to investigate about this. So you will say how you to investigate for the thrombosis.
Doppler.
Yeah, Doppler ultrasound for the renal or the pelvic kidney, right?
Yes.
Yeah. What else in the neck you can find? As Dr. Muhammad said, the scar and what else? Something important.
The permacath.
Permicat, what else?
Mm, the lymphadenopathy.
What else?
There's JVP.
What else?
Not sure.
Any cancer, skin cancer, it will appear here, right?
Yeah. Yes. Yes.
Immunosuppress. Or any scar for the removed cancer or excised cancer, skin cancer or mass, right?
Yes.
So be sure that you are examining the neck, not only from the front, even from the sides and the back.
Okay.
The lymph node is very important here. You can offer even the inguinal lymph nodes examination because you have pelvic kidney, right?
Yes.
And the last thing I want to mention the back. Yes, if you have liver patient or hepatic patient, you examine the back for what? And in our patient, you examine the back for what? In the hepatic patient, what do you examine in the hepatic patient? The back, I mean.
For basal crepitation, sacral
Okay,
edema,
okay, and
and
hepatic cirrhotic patient.
I'm not sure.
Spider nevi.
Yes, spider nevi. It will be in the back as well, right?
Yes, exactly. It can be in the back and the front, but I mean, you have to scraper it at the back, not only the front. Then for kidney patient or a renal patient, the back for, as you said, by basal crackles or sacral edema, or as I said earlier, the scars for nephrectomy if you have unpalatable one kidney in one side. Clear now?
It's clear.
Yes. Otherwise, generally well, but try to be more concise. They will not give you a chance to present all this time. But as we are training and teaching session, we are trying to expand the time for the examiner, but it's not that real in the exam. The
Okay.
reality, it will be different totally. 1 minute he will cut, then he will skip to the next part, then he will cut or interrupt you, asking for the investigation, then the management at the end. 4 minutes only. Okay?
Okay.
Any question, Dr. Kotov?
No, it's thank you.
Thank you. Dr. Muhammad, also, you have any question or comment? If you're still there.
Thank you.
Okay. Anyone want to comment or add comment or suggestion? Yes, Dr. Inas, thank you. Okay. Okay. Anyone want to add any suggestion? Any unclear? Clear for all? Satisfied? So we can end the session. Thank you, everyone. Thank you, Dr. Muhammad, Dr. Kotov, Dr. Hind, as usual. And thank you for the attendance, everyone. Thank you, Dr. Ala. See you tomorrow, inshallah, with long clinical consultation day. To be honest, there is some candidates messaging me about practice, but I will give some priority for those who's having near exam. Okay, I have a lot of requests. To be honest, I will give priority to those who's having near exam. Okay, so please don't be bothered if I give the priority for others or the opportunity to others. See you tomorrow, inshallah, long clinical consultation day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you very much, Doctor.
Thank you.